sense to answer this question: should we operate or perform spine surgery on patients over 80? And the short answer is maybe. The slightly longer answer includes a case. In my practice, if a 89-year-old patient gets in, I usually yell at my nurse because I have junior partners to see the older patients. And the question is always, why would you want to bother with an older patient? It's a lot more trouble. But there are cases where treating an elderly patient is surgically makes sense. And this is a lady who had a long history of mild to moderate back problems, but was doing well with them until she fell. When she fell, she sustained a compression fracture, but rather than having back pain, she had increasing leg pain and then claudication. That increasingly limited her ability to ambulate, and by the time I saw her, she was transferred to a nursing home because she was having trouble transferring to the shower and to the commode. They tried pain medications, a corset, they tried an epidural. None of those things helped her. This is her CAT scan. You can see the fracture, the poor quality bone. You can see fairly massive facet hypertrophy at the L4-5 level. Her MRI shows fairly significant stenosis associated with that facet hypertrophy, and you can see on the saddle view the edema, the fracture cleft, and so on. So is surgery reasonable in this patient? And if so, what kinds of surgery would you consider? Are there other questions we should be asking to make a better assessment? I think for this patient, it's important to know that she's in a nursing home now, but until this all started, she was a very functionally active, independent 89-year-old. She does have some kidney and heart problems, but she's cognitively normal. And so we did a fairly straightforward procedure, kyphoplasty, and then a decompression. Took under an hour. She has a little incision there. You can't really see the kyphoplasty incisions. This is actually not her. But it was surprising to me. I thought that it would take her a long time to recover based on her age, but she was able to walk very shortly after the procedure. She did require about 4 days in the hospital, which is 3 days longer than our insurers usually will cover for this kind of procedure. And then she spent a week in the rehab center, mainly for stability and endurance issues. But in this case, it was a home run. And that takes us back to the consideration of who's old and what does that really mean. The geriatricians and the gerontologists give us these age breakdowns for the elderly, but what we're talking about is mainly patients over 80 at this point. We know that beyond chronological age, there are a number of other factors that have to be considered. 80 is not 80 is not 80. That physiologic age can be very different from someone's chronological age. We know that some people age differently, some people age better than others, but we also know that aging isn't linear for people. Some people will have long periods where they're fairly stable and then sudden worsening. The common trope in the U.S. media is to show the U.S. president before and after a term or two in office. There's President Bush, there's President Obama. The argument being that they aged quite a bit more than the 8 years. For most people that treat adults in the world of spine surgery, this is going to become an increasing part of the practice whether you like it or not. In the US by 2050, this will be 27% of the population. In Japan, it'll be nearly 50% of the population by 2050. And virtually every country is seeing a growth in the population of the elderly. Saudi Arabia is no different. If you look at the growth of the population of the elderly, we're at the upslope part of the curve here. Interestingly enough, the rates of surgery in elderly patients has actually increased faster than the rate of increase of them in the population. And that's thought to be due to improved anesthesia and surgical techniques, lowering the morbidity of surgery, as well as increased patient expectations that they be treated surgically. And so when we think about working with a patient and deciding what's right for them in this setting, it is important to understand their life expectancy. We know that varies considerably with gender, with birth year, wealth, country. But we also want to know what patients expect from life and where their current activity level is and what they expect to get from the surgery. This is a activity graph that's normalized on 50-year-olds. And if you look, the 80-year-olds are still participating in sporting activity at about half the level of the 50-year-olds, so not the same, but certainly not zero. And they're walking at about 75% of the level of a 50-year-old. What we often see in the medical world is when a patient has a functional decline, whether it's a fracture or a sciatica episode, they stop moving, and as they stop moving, they become weaker, they start developing some cardiopulmonary decline, and then the cycle progresses ultimately to an earlier death. And so the issue is, when is spine surgery justifiable to break that cycle? I remember having residents ask me, if you have this 80-year-old patient, you do a surgery that might take them a year to recover from, haven't you used up all their remaining time on earth recovering from your surgery? And that's a misunderstanding of how life expectancy tables work. This life expectancy table tells you that a woman born in the U.S. in 2015, the year the table was put together, was going to live 81.3 years. But if you made it to 80, you're likely to live another 9+ years. And if you're healthy, active, and independent, it's even more than that. So these patients are not going to die tomorrow. On the other hand, we can't ignore the risks. Risks go up, recovery times are definitely longer. There's a Truumees database study of more than 55,000 patients undergoing surgery for lumbar degenerative disease, and more than 10,000 of them were over 80 years old. And they saw significantly longer hospital stays, more in-hospital mortalities, and more complications. So here again, there's some of the factors we want to consider. I think other important issues are close collaboration with their other medical specialists. This requires phone calls and more engagement than you might with healthier, younger patients. And family input's critical, having the family members come to the office visits. Sometimes particular studies can help hone things down too. This is the Japanese multicenter study. They looked at 262 spine surgeries in patients over 80, and they had a fairly decent complication rate with 29% complications, but no deaths. And they found major risk factors for those complications included age over 85. The comorbidities that were worse were diabetes and cerebrovascular disease. But interestingly, on the surgical control side, blood loss greater than 500 cc's and surgery longer than 3 hours were major risk factors. We can put our surgical factors up against a sense of frailty for the patient. There's no consensus definition here, but frailty is thought to be a measure of physiologic reserve across multiple organ systems. A frail patient is one who, even at baseline, is barely hanging on, and any external stressor is likely to push them over into failure. And surgery is obviously not going to be a good idea in that patient age group. And so frailty measures tend to be most useful in the older old patients, where it's been found to be an independent risk factor for mortality, morbidity, and institutionalization. There's several different ways you can look at this, from simple to very complex. There's the comprehensive assessment of frailty. I'm not sure that that's necessary for the spine surgeons here, but simple things like looking for sarcopenia and cachexia, grip strength, time to get up and go. These are helpful ways of identifying the more robust from the frailer elderly patient, aside from just the comorbidities. I find these risk calculators very helpful. This is the Spine Sage system, which is University of Washington. The link is at the top here. You put in the patient's demographics, their medical comorbidities, and some surgical details, and you get a printout of risks. This particular one has major complications and any complications. And so I put in the 89-year-old example patient we had earlier, and this is the risk profile it came up with. And then I put in the exact same risk profile for a 50-year-old, and the surgeries were divided in invasiveness. I selected level 5 out of 35 to represent the surgery we did. And you can see that the major complication rate goes up from 2 to more than 6%. The any complication rate goes from 10 to more than 23%. So in conclusion, surgery in patients over 80 can be reasonable, but you have to get to know the patient both in terms of their previous activity level and health, but also any signs of frailty. Patient expectations are critically important, as are family expectations, and a careful explanation of the risks of the procedure to not only the patient but the family, and phone calls with the other caregivers explaining exactly what you intend to do from a surgical perspective. This team-based care does take a bit more time, a bit more phone calls, but these are often very happy patients. If you have any complications, it's critical to jump right on them, especially things like delirium, and you want to make that surgery less than 3 hours. You're not going to do a T10 to the pelvis on these patients. Limit them to the major symptom that brings them in. Thank you very much.